A very good evening, everyone. We hope you're making the most of the clinical discourse planned for DocPlex's Global Diabetes Summit for our dear doctor community. We hope you have registered for this A.CME session in advance in order to avail 1 credit point and your certificates. Today's CME is planned around trend talks on diabetes today and beyond. We have 3 speakers today, Dr. V. Mohan, who shall be talking about reversal of diabetes, hype or reality. Second speaker is Dr. Supratik Bhattacharya, who shall be speaking to us about COVID-19 and diabetes. And our last speaker, Dr. Ina Shaltut from Egypt, who shall be talking about recent advances in therapeutics in diabetes. I would like to welcome all the 3 speakers for today. Starting with Dr. V. Mohan. He is the chairman and the chief of diabetology at Dr. Mohan's Diabetes Specialties Center at Chennai, which is an IDF center of excellence in diabetes care. Dr. Mohan oversees a chain of 50 diabetes centers across 8 states of India and has over 540,000 registered diabetes patients in his center. He's also the president and director of the Madras Diabetes Research Foundation. Dr. Mohan has received over 190 awards, including the prestigious Dr. B.C. Roy National Award by the Medical Council of India, Dr. B.R. Ambedkar Centenary Award, the highest award for biomedical research given by the ICMR, and also for his extensive contribution in the field of diabetes. In 2012, Dr. Mohan was awarded the Padma Shri, which is the 4th highest civilian award given by the Government of India. It's a pleasure to host you today, sir. Please enlighten us with your talk.
Hello, everyone. At the outset, I would like to wish you all a very happy World Diabetes Day. As you all know, World Diabetes Day is to commemorate the birthday of one of the greatest heroes in the field of diabetes, Dr. Frederick Banting, who discovered insulin. In India, diabetes is rising very rapidly. We have close to 80 million people now with diabetes in India, and these numbers can go up very much. And therefore, today's topic about reversal of diabetes becomes very important. Only thing is there's so much of hype around diabetes reversal that I wanted to give a balanced view about diabetes reversal, and the topic itself is somewhat contentious. Is it a hype or is it a reality? To start with the first slide, I'm showing you the natural history of diabetes. We know that when we are born, we are in the stage of normal glucose tolerance, so we are normal. Then after a few years, we develop pre-diabetes and then diabetes, and some unfortunate people develop complications also. So usually the natural history of diabetes is shown this way, going from left to right. But more recently, we have got evidence that you can also go from right to left. And you can see that this blue arrow is showing reversal. But you can see that the blue arrow is not there in the stage of complicated, which means your eye, kidney, heart, feet are already affected. What reversal are you going to have? But if you're in the stage of clinical diabetes, you can reverse. In the stage of pre-diabetes, you can reverse. This figure may look new to you, but 40 years ago, I made this figure, and it's there in many textbooks. Because even at that time, including the blue arrow, I had put there saying that, yes, in selected cases, reversal is possible. But today we have more data, and that's what we're going to talk about. Okay, so we're talking about going from right to left now. Now, the traditional concept of type 2 diabetes is that it's a progressive condition. There is no cure, no reversibility, and it will go in only from left to right, as I showed you. But then there is evidence that you can go from right to left. Also, another disclaimer that I'd like to have is that only in type 2 diabetes, we talk about reversal of diabetes, and also in gestational diabetes. I'll come to that. But there are types of diabetes like type 1 diabetes, fibrocalcific pancreatic diabetes, surgery-induced diabetes, these kind of things where there is no reversal at all. And therefore, we must be very specific that we are talking about this, because I've seen even children with type 1 diabetes being misled by quacks who say we can reverse your diabetes. Please reverse it, and please get some Nobel Prizes for India. I would like several Nobel Prizes to come. So please reverse and get your Nobel Prize. As of now, it is not reversible. Okay. So I'm giving here 5 examples of reversal of diabetes. The first is after severe weight loss, and I'm going to talk only about that in the rest of my presentation. But remember that after GDM, if the gestational diabetes goes away after the delivery, that is also an example of reversal. After bariatric surgery, you can lose 40-50 kilograms after bariatric surgery. So many people can reverse, especially those who achieve reversal after weight loss can also achieve it after bariatric surgery. It's probably more permanent also. Stress-induced diabetes. We all know that COVID produced diabetes due to stress, worry, anxiety, depression. Once that all goes away, then diabetes also may go away. Finally, drug-induced diabetes has shot into fame recently because again, COVID, steroids being used, large doses, producing diabetes, even the public knows about this now. Obviously, if you stop it, in many people will go away. But in this presentation, I'm not going to talk about 2, 3, 4, and 5. I'm just going to talk about number 1 after weight loss. Now, the American Diabetes Association defines remission of diabetes. They don't like the word reversal because they say it can always come back. So you don't use the word reversal. They encourage you to use the word remission. What is remission and how is it defined? In a person with diabetes, type 2 diabetes, who was already taking tablets or insulin, if the tablets and insulin are stopped and still the HbA1c remains less than 6.5 and the fasting remains less than 126 for 3 months at least, then they say remission has occurred. Now, why is the term remission preferred to reversal? Because there are other examples. Cancer, for example. Somebody can have cancer, then you do radiotherapy, chemotherapy, surgery, all hormonal treatment, do all that. Suddenly you find there's no cancer now. You do a PET scan and it becomes normal. The cancer has gone into remission. That remission can last for 6 months, 1 year, 2 years, sometimes even 10, 15 years, they can be in remission, but it can always come back. And when it comes back with a bang because it comes back as metastasis. In the case of diabetes also, I'll show you that although remission can occur, it can come back and come back with a bang. There are other definitions. The direct study, for example, says it should be more than 1 year. Whichever definition you want, you can use, but the ADA definition is popular. The 2 diets which are used to induce remission, one is called as a low carbohydrate diet or the LCD, and the very low calorie diet or the VLCD. As the name itself suggests, the low carbohydrate diet, you have to reduce your carbohydrate or the carb intake. In India, the high carbohydrate diet is defined as more than 45%, but in India, we take 70%, 75% carbohydrate. Okay, so obviously far too high. As the carbohydrate content comes down, you can call it as moderate carbohydrate, low carbohydrate, and very low carbohydrate diet is less than 10% of your diet having carbohydrate, or only 20 to 50 grams of carbohydrate for the whole day, not for one meal, for the whole day. Okay. Now, with such a low carbohydrate diet, obviously the sugars will come down and you can achieve remission. There are 2 problems with this. One is sustainability. In India, who is going to continue on a very low calorie diet for years and years and years together? Very, very few people. They try it for a few months and they say, no, I cannot continue this, and sustainability is not there. Second, there is also a medical reason. If you take 10% carbohydrate, or some take even 0% carbohydrate, protein can be only 20%. That means 70 to 80% of your diet is going to come from fat. Very high fat can increase your LDL cholesterol, your bad cholesterol, and can produce coronary atherosclerosis. And therefore, a very low calorie diet in India is difficult. The second diet which is used is called as a VLCD, or the very low calorie diet. This is where a lot of studies have been done. And if you take about 800 calories for the whole day, it's practically like starvation. Okay. If you are able to take 800 calories per day, it's called as a very low calorie diet. Now, in my experience, both work. Of course, when you reduce the carbs, the sugar comes down, weight comes down, everything comes down, medicines come down. But also, if you restrict your calories, also the same effects. So to me, it really doesn't matter which of these you follow. Now, this is a famous slide from Roy Taylor from Newcastle. He showed that there are 2 places where there is a problem with diabetes. First is the liver. When you have a positive calorie balance, means you're eating more and more and more, you're not able to expend that energy. Then what happens is liver fat accumulates because it's for storage, and that produces resistance to insulin. So your insulin resistance is going to go up whenever your calories go up and when you put on weight. There's one more place where this kind of problem occurs, and that's in the pancreas. Fat accumulates in the pancreas, and pancreas is where the insulin is secreted from the beta cells. When you have too much of fat in the pancreas, the beta cells are not able to produce insulin, and therefore your insulin secretion also goes down, insulin resistance also goes up. Both the defects in type 2 diabetes are there. And this is called as a twin cycle hypothesis. Question is, can this be reversed by a very low calorie diet? Now, the physiology behind this is that within a week after starting a substantial negative balance. Suppose you're taking 3000 calories. Now you have come down to 1000 calories or 800 calories. What happens is suddenly the liver fat starts melting because the liver has to substitute for this, and therefore it will first get rid of all the fat. And then your hepatic insulin sensitivity will become normal. Insulin will now work very well now. After about 8 weeks, this is in the first 1 week. After 8 weeks, the pancreatic fat will now start melting. And now your pancreatic function, beta cell function will also improve. That's what is shown here. You can see within the first, this is the second week and that's the first week. The first week itself, sugar is falling, hepatic glucose production is falling, and hepatic triglyceride or the fat is coming down. And by 8 weeks, you can see that the pancreatic fat is also coming down and insulin secretion is improving. Here is one tip for you to remember. It is likely that type 2 diabetes is caused by less than 1 gram of fat. Did you know this fact? You should know that. But to get rid of that 1 gram of fat, you have to lose 15 kilos in weight. If you lose 15 kilos in weight, 1 gram of fat will go and your insulin secretion will improve. Your diabetes will go into remission. That is what is shown in the diabetes remission clinical trial, also called as the DocRed trial, done in the UK by Roy Taylor and colleagues. What they did was that they took 300 patients, divided half into intervention arm, half in the control arm. Intervention arm had a near starvation diet, 800 calories per day, continuously, months after month after month, only 800 calories per day, breakfast, lunch, dinner, all put together. Usually they took it as a drink, so that the measured amount of calories, that's it for the whole day, okay? And so with that, they tried to see what happened. Control group had normal diet. So what they found was after giving this kind of starvation diet for months together, only 800 calories, they were able to achieve remission in less than half. Only 46% of people achieved in the intervention group and 4% in the control group. Okay, now if you divide it by the amount of weight loss, in those who lost only less than 5 kilos in weight, virtually nobody had remission. As they lost more and more weight, 5 to 10, 10 to 15, more than 15, the amount of remission went up. That's why I said you need at least 15 kg weight loss. Now, the obvious question you'll ask me is, what will happen if that weight loss is not maintained? If it's not maintained, your remission will go. Even if the weight loss is maintained, you can see the weight loss is maintained in these people. Out of this 86% who achieved remission, 16% lost it. And it came down at the end of 2 years to 70%. And with time, it will start going away. So these effects are very rarely permanent. And therefore, you have a chance of the diabetes coming back. And that's what I'm going to describe in further detail. So the conclusion of the DocRed study was that if you take very obese people who have short duration of diabetes and have profound weight loss in them, about half may be able to go into remission for some time. Okay, maybe for a year. Now we have evidence up to 2 years. Who does reversal work for? Now, this is a question which everybody asks. I have a person who's got 30 years of diabetes. He's taking 100 units of insulin. His HbA1c is 15. Can I try reversal for him? Don't try, because I don't think it'll even work. Remember the ABCDE mantra for reversal. A stands for A1C. If the A1C is not very high, say 8, 8.5, they are likely to develop remission more. I'm not saying somebody with 10 or 11 will not, but the chances are much less. B stands for body weight of BMI. The higher it is, the greater the chances that you can lose 15 kilos and therefore you can achieve remission. C stands for C-peptide. It's a measure of insulin secretion. If your C-peptide is good, your chance of having remission is more. D stands for duration of diabetes. Shorter the duration of diabetes, the more likely you will get remission. And E, most important than A, B, C, D, is enthusiasm. Unless you have a highly motivated person, how are you going to get remission? Imagine this person has to continue with that diet for month after month after month after month after month after month for lifelong. Okay, how many human beings can do that? Right from Adam and Eve's time, we say don't eat that apple only human beings want to eat. That's a human nature, Right from Adam and Eve's time, it was there. So imagine somebody going on, no, I'll eat that 800 calorie for the rest of my life, my next 50 years, I'm going to eat this. It doesn't happen. And that's why you need highly enthusiastic people to be able to achieve this. Okay. And effectiveness beyond 2 years has not been shown. And what I'm going to talk about in the next 5 to 8 minutes is about reversal of diabetes. Something which I have not heard anybody talk about this. Everybody talks about reversal as if it's a mantra. and as if it is a magic a cure for diabetes. Particularly non-doctors are the ones who are promoting this more. A computer engineer now gets into this business and he says, I can cure all of you. Okay, they don't know even the physiology of diabetes, but they talk about reversal. We clinicians who are seeing this and daily seeing our patients know what happens to them in the long run. So what is reversal of diabetes? It is something where the diabetes is coming back after remission. If I show you a case study, it will become clear to you. This is a young man, 36 years old, short duration of diabetes. So the A, B, C, everything is coming in here, very much obese. And so therefore is an ideal candidate for reversal. We put him on a low calorie diet, low carbohydrate diet. He lost a lot of weight. He was very happy when he achieved reversal of diabetes. In fact, he stopped all medicines, all insulin, everything, and he maintained remission. He was the happiest person. Look at his body weight from 123, 118, 116, 102, 99. So he's lost 24 kilos in weight, not even 15, 24 he has lost. Naturally achieved remission. HbA1c from 8.4, 5.4. By the time he came here, everything we stopped. Insulin, tablets, everything we stopped. And he continued to be under reversal or remission. Fasting blood sugar came down from 132 to 89. Postprandial from 293 to 110. You can see 89, 110 is very good. So over a 2-year period, he's gone into complete remission. Okay. LFT, SGOT and SGPT shown here. SGOT came down from 61 to 16. And SGPT came down from 94 to 20. So you can see they're all normal. The liver fat has gone away. You can actually see it in this LFT. So now what happened? He stopped all his medicines. He forgot about his diabetes. He told everyone, I'm cured, I'm cured, I'm cured. We called him back. After about 3 months, we said, very good, you're cured now, or you've gone into remission. Why don't you come and see us? Why should I come and see you, doctor? I am completely cured. No, sir, let's see whether you're really cured or not. I mean, you just come and see us. We'll see your weight. We'll see everything. We'll check your metabolic thing. It's still important. No, I will not come, he said. He didn't come. After 9 months, sheepishly, he came back. I asked him, what happened? I'm not feeling well. I'm feeling very tired, So just check me out. When he saw his weight, that increased by 13 kilos. Now, remember, he lost 24 kilos. He's only gained 13. So he's only gained half the weight which he lost. Okay. But see the impact of that. HbA1c, his highest, his worst was 8.4. Now from 5.4 to 9.6 he went. Now look at the time duration here. This is November 2020. This is August 2021. 9 months have passed. This 9 months has gone from there to there to there to there to there. What if he had just come back after 2 months? It would have probably gone to 6 or 6.5. We would have told him, motivated him. Again, we would have brought it down. Again, it would have come down. Okay. So if only he had maintained the contact with us, we might have been able to help him and not have this disaster of the A1C going up to 9.6. Look at the sugars. Fasting 132 was his highest. Now it is 247. Fasting. PP had never gone above 300, 293. Now it is 321. Okay. It's gone sky high. Liver function. At his worst time, SGPT and SGOT were 94 and 61. Today it's 152 and 66. Completely gone. From 20 to 152, straight it has gone. From 16 to 66. That means it must have gone here, 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 here. Somewhere here we would have told him, hey, things are going out of hand, man, let us bring it down. But he never gave us a chance. This is overconfidence. Overconfidence and people telling him, no, this is all cured, don't go back to diabetologists. They are the worst breed of doctors. Never go back to them. They will tell you to take medicine. They will tell you you must take insulin. They are bad people. Don't go to them. This is what is being told. But actually the truth is like this. And nobody brings this out. Nobody talks about it. Will this man go to social media and say, oh, my weight came back, my sugar came back? Never, never. Only the before-after picture. After they lose weight only, they'll show you. They'll never talk about the other side of the story. Okay. So this is an example of reversal of diabetes. You may ask me, is this one case you have seen? I've seen hundreds of such cases. I can't show you 100 cases now in the short presentation. I'm making a publication. I'm going to publish it. I've seen people go into remission and come back. Go into remission, come back even worse, like the cancer coming back, as I told you. So, ladies and gentlemen, I'd like to conclude by saying that conversations with people with type 2 diabetes should include discussing remission. That's very important. Today, we have the evidence that this can occur, that it can go from right to left also, from diabetes to pre-diabetes to normal. So therefore, start discussing. Identify that A, B, C, D, E people. Who are the people with lower HbA1c, shorter duration, very much overweight, highly motivated people? They have good C-peptide. Bring them in and see whether we can try to reverse. If they are motivated, okay, but they must be willing to follow it for a long time. Dietary approach is very important. Don't go only by low calorie and low carbohydrate. As long as they reduce their calories and develop negative calorie balance, they can go into remission, but exercise is also important. You need to be in touch with them. A structured program is very important. The dietitian, the educators, keep on talking to them. Only then you will be able to continuously motivate them. But in many cases, re-reversal of diabetes occurs. This is hardly emphasized. I can tell you, I have not heard this before. Anybody talking about re-reversal of diabetes. So the limited point I'm trying to make is, even if somebody has gone into remission, please keep in touch with the doctor so that if you continue to be in remission, somebody will say, oh, I've seen one case who had 5 years remission. Good for him. Very good for him. Let him keep it up. I want more people like that. But more often than not, I see the other way around. The sugar coming back in a very bad state. And sometimes their organs also get affected because they've been following all kinds of fad diets. So be careful. Reversal of diabetes is not a joke. It is not a commercial thing. It is not something for non-doctors to do and so on. It can do harm. If you're not careful, it can do harm. So on that note, I would like to stop here. And if there are any questions, I would be happy to take. Thank you very much.
Thank you so much, Dr. Mohan. Indeed, a very well presented talk. I am sure our audience is taking notes and would be taking away some key points from this discussion. Moving ahead, our next speaker for today is Dr. Supratik Bhattacharya, Director of SKN Diabetes and Endocrine Center in Dunlop. Dr. Supratik Bhattacharya is an eminent consultant endocrinologist, diabetologist practicing for more than 14 years. He is a member of Endocrine Society USA, Fellow American College of Physicians USA, etc. His main area of specialization includes diabetes management, gestational diabetes management, diabetes renal failure, insulin treatment, thyroid disorders, etc. Welcome, Dr. Supratik. Please share your screen and go ahead with the presentation, sir.
Good evening, everyone. I'm Dr. Supratik Bhattacharya. I'm consultant endocrinologist based at Kolkata. And thank you, DocPlexus, for this invitation to talk on a very pertinent topic, COVID-19 diabetes. This topic is as pertinent as it was in December 2019 when COVID-19 was first introduced, and it's as relevant now as it was before. So this is my introduction slide, and it's a pleasure being on board on DocPlexus as an expert for endocrinology, and we had a very good association from the very beginning, and hope you enjoy the session today. So COVID-19, as we know, this was discovered in December 2019, a novel coronavirus, which was first sort of emerged in Wuhan, Hubei province in China. And there were also a few cases of pneumonia in children with SARS-CoV-2 infection was reported. This is one of the early newspapers which reported the COVID-19 virus. So very soon across the world, you saw newspapers and the TV channels covering about this COVID-19 infection. And we know that it took the form of a pandemic very soon. And the concern was that it was causing a lot of morbidity and mortality. So going into the epidemiology of COVID-19, in December 2019, clusters of pneumonia, cases of unknown etiology emerged in Wuhan, Hubei province, as we were saying. Deep sequencing analysis from the lower respiratory tract samples indicated a novel coronavirus as a causative agent, which was called severe acute respiratory syndrome coronavirus 2. And the disease it caused was called COVID-19. And although SARS-CoV-2 has shown phylogenetic and clinical similarities with an earlier strain called SARS-CoV, the novel coronavirus appears to have a higher transmissibility as well as lower case fatality rates. However, standing today in 2021, we know that the fatality rates with COVID-19 was as high and concerning. So on 30th January 2020, WHO declared COVID-19 outbreak as a public health emergency of international concern. And by the time it was March 11th, the epidemic was upgraded to a pandemic status. COVID-19 and diabetes interrelationship. The relationship between COVID-19 and diabetes mellitus is complicated and bidirectional, as we were saying. On one hand, diabetes mellitus is considered as one of the most important risk factors for severe course of COVID-19. And we know that anyone with dysglycemia or uncontrolled diabetes has got a more severe outcome in terms of morbidity and mortality. And there are several factors that are often present in diabetes, which are likely to contribute to this particular risk, like an elderly individual, a pro-inflammatory state, a hypercoagulable state that is often associated with this condition, hyperglycemia, and underlying comorbidities that are associated with type 2 diabetes, like hypertension, cardiovascular disease, chronic kidney disease, as well as obesity. On the other hand, a severe COVID-19 infection and its treatment with steroids, and often we know that anyone acquiring a moderate to severe COVID-19 infection and ending up in the HDU or ICU and requiring oxygen as well as steroid support will have dysglycemia that extends well beyond stoppage of the steroids per se. So this can have a specific negative impact on the diabetes itself, leading to worsening of hyperglycemia through increased insulin resistance and reduced beta cell secretory function. Now, worsening hyperglycemia can in turn adversely affect the course of COVID-19, and although more knowledge gradually surfaces as the pandemic progresses, challenges in understanding the interrelationship between COVID-19 and diabetes still remain, and we are gradually learning more and more about this every single day. So the burden of diabetes, if we talk about, it's a complex chronic disease characterized by glucose dysregulation caused by an absolute or relative insulin deficiency. And we know that grossly it is of two kinds, the type 1 diabetes and the type 2. And the type 1, of course, is autoimmune destruction of the insulin producing pancreatic beta cells. Whereas in type 2 diabetes, what we know is that there is a beta cell secretory defect as well as insulin resistance. And if you look at the global burden of diabetes, it's very high, and overall prevalence is about 9.3%, and 463 million people are suffering from diabetes worldwide. If you look into India, about 77 million people are suffering from diabetes. But more concerning is the number of pre-diabetic individuals who has got an HbA1c between, say, for example, 5.7 and 6.4, or they have impaired fasting glucose or impaired glucose tolerance, and they're completely unaware they are harboring this disease. And COVID-19 changed the scenario, because many times we are getting to know incidentally while they're getting their blood glucose levels checked during this infection that they were probably pre-diabetic before, and because of the pro-inflammatory state, they're converting into diabetes, or there is often a dysglycemia that is associated, and that is being sort of brought out during the disease process itself. So various comorbidities and long-term complications, including obesity, hypertension, vasculopathy, pro-inflammatory and hypercoagulable state, and of course, cardiovascular disease is not uncommon. And double-edged sword, diabetes and COVID-19 is something that we are dealing with day in and day out nowadays. And of course, we need to understand the interrelationship between them. And we know that for once that it's a bi-directional relationship between COVID-19 and diabetes. On one hand, diabetes and its associated comorbidities increase the risk of more severe course of COVID-19 and increase mortality. As we were saying, once a diabetic individual with dysglycemia or uncontrolled diabetes develops COVID-19, and they're known to have an increased risk of infections, which is partly attributed to the hyperglycemia causing immune dysfunction among the effects. On the other hand, severe SARS-CoV-2 infection and its associated hyperinflammation contribute to hypoglycemia, mainly by two methods, either indirect negative effect on the insulin target tissues and a potential direct negative effect on the pancreatic beta cells. The resulting hypoglycemia can in turn, of course, worsen the prognosis of COVID-19. And this is a very interesting diagram that you see in here. Multiple comorbidities that are associated with type 2 diabetes, as well as type 1 diabetes, whether it could be the cardiovascular disease, chronic kidney disease, obesity. Diabetes by itself is a pro-inflammatory state and also a hypercoagulative state. And also, if you look at the demographic features, we're saying the condition is more prevalent in elderly individuals. It's worse in the male sex, non-white ethnicity, because of the Indian phenotype carry a lot more fat around the waist. And because of that, we have a much higher insulin resistance. And also it's more predominant in the low socioeconomic status. Now, over on top of this, in this glycemic patient, if somebody acquires the SARS-CoV-2 infection, we see is that there is a diet that falls on the impaired beta cells which produce insulin. And because of that, either the pancreatic beta cells reduce in number or the secretory function is affected. And this is hypothetical at the moment, and that might lead on to hypoglycemia. Similarly, because of the hyperinflammation and treatment with steroids, what we see that there is a higher insulin resistance, which lasts beyond the stoppage of the steroids. And because of that, also, we have hypoglycemia. And the net effect, of course, is a more severe cause of the COVID-19 and increased morbidity and mortality. Now, diabesity is again a term which has been coined because there's a frequent association between type 2 diabetes and obesity. And obesity has an extensively linked to severity and mortality of COVID-19 infection. And several mechanisms has been suggested to explain a strong association between obesity and severe course of COVID-19. And we know that ventilatory difficulty, hypercoagulable state, pro-inflammatory environment present in obesity, as well as alterations in the gut microbiota, nutritional deficiencies, and immune dysregulation could be one of the reasons as well. So obesity is also linked to diabetes. And as we were saying, that there is a term that has been coined, and it's called diabesity and has been used in literature. And individuals with increasing BMI have an incremental increase, the risk of developing diabetes, already starting at an overweight BMI. So anywhere between 25 and 29.9, we know that there is a much higher association between obesity and more severity of the COVID-19 infection. I must emphasize that for Indian individuals, this cutoff of BMI is much lower. So for us, anyone with a BMI of more than 23 should be considered overweight. This particular risk increases as the obesity class increases through from class 2 up to class 3. We see a much higher association and much higher odds ratio in terms of the severity of the outcomes when a person acquires COVID-19 with obesity. So with both diabetes and obesity, they provide the common soil, like the pro-inflammatory state, hypercoagulable state, and as well as immune dysregulatory conditions, and additional effect on the obesity on severity of the COVID-19. We have data across the globe. So the French nationwide cohort study showed that BMI was independently associated with their primary outcome, which was tracheal intubation or death within 7 days, and the odds ratio was 1.24. USA prospective cohort study found that for each 8.9 kg per meter squared increment to be associated with a higher adjusted odds ratio of about 1.25 for hospitalization. And an effect on the COVID-19 related mortality was found in the UK population-based study, which showed a U-shaped association between BMI. So anyone with a very low BMI as well as a very high BMI in both type 1 and type 2 individuals where they were at additional risk of death when they acquired COVID-19 infection. So diabesity and COVID-19, so we've clearly sort of defined that there is a definite association with the higher BMI and severe outcome. And we have also shown that the lower BMI is equally affected when they acquire the infection. Now, coming to the risk of adverse COVID-19 related outcomes, and we know that anyone with type 1 or type 2 diabetes, we know that the outcome is worse in terms of mortality or hospital ICU admission if they have type 1 diabetes versus no diabetes. Similarly, a much higher chance of mortality in those individuals who have a type 2 diabetes which is not controlled versus anyone with no diabetes. And this has been found very consistently in various studies done by Barron et al. Or Gurnam et al. Or Gregory et al. So this is very similar in terms of the outcomes and the severity after acquiring a COVID-19 infection. Coming to the glucose-lowering therapies, the benefits, risk, and recommendations with the various glucose-lowering therapies during a COVID-19 infection. And we know that insulin is considered to be relatively safe and careful. The benefits that you get from using insulin is, of course, it improves the glucose regulation, and also it is better in terms of COVID-19 outcomes. Risk, however, remains that there is chances of hypoglycemia in combination with certain other drugs that are co-administered during the COVID-19, like hydroxychloroquine, which was being used earlier. High doses would be needed in critically ill patients and those using steroids. And the recommendation is do not discontinue the insulin once you've initiated in those with severe COVID-19. Metformin, again, a very good agent, and it's probably the first line anti-diabetic that we use. It's an anti-inflammatory property and no chances of hypoglycemia. However, in critically ill patients, there are chances of lactic acidosis, and you should be watchful while using metformin in ICU setup. So discontinue patients with severe course, impaired renal or hepatic function, sepsis, heart failure, and respiratory distress. If you're talking about sulfonylureas, again, not much benefit pathophysiologically. The risk is of hypoglycemia, especially in combination with other agents. So consider discontinuation based on the COVID-19 severity. If it's mild to moderate, you can continue with any of these molecules, but if the person requires hospitalization or ICU or H2 care, it's better to discontinue the secretagogues like sulfonylurea, and also check on the nutritional status and risk of hypoglycemia. SGLT2 inhibitors, again, no hypoglycemia at all. Risk of diabetic ketoacidosis and dehydration in severely ill. So the recommendation earlier was to discontinue in patients with a severe course of the disease, like impaired renal or hepatic function, sepsis, heart failure, respiratory distress. However, with the ongoing studies and the recent data that is being generated, like with dapagliflozin in the DARE-19 study, we know that probably these molecules might be of benefit even in the hospitalized individuals. GLP-1 receptor agonists or the incretin-based therapies are very helpful because pathophysiologically, they have anti-inflammatory property with no hypoglycemia, the risk of dehydration and side effects like vomiting and diarrhea. So do not discontinue, however, and encourage the patient to be hydrated well. DPP-4 inhibitors, again, is incretin-based therapy, which is well tolerated, no hypoglycemia, and also you can continue with this, very minimal risks. So do not discontinue if it is ongoing at the moment. And also a very effective molecule when you're trying to step down from a basal bolus insulin regime post-discharge. Thiazolidinediones like pioglitazone has got an inflammatory property, reduction in the insulin resistance. However, the risk of fluid retention and aggravation of the heart failure remains. And so the recommendation is consider discontinuation in patients with severe course of the disease, particularly patients with heart failure. Anyone co-administered with statins, please do not discontinue. Anyone who has been well controlled of their blood pressure and been using ACE or ARB, do not discontinue and continue with the treatments. Coming to the next point, that is the risk of adverse COVID-19 related outcomes according to the glycemic control. And here we're looking at the glycemic status before hospitalization, at the time of hospitalization, and also the glycemic control during the hospital stay. And what we are looking at, the primary outcome is in terms of mortality, severity of the disease, hospitalization, and it doesn't matter whether the person was dysglycemic before hospitalization, at the time of hospitalization, or they were dysglycemic during the hospital stay. What we see is that there is an increase in the mortality. So the whole idea is to control the blood sugar in both type 1 and type 2 diabetic patients very well, even prior to hospitalization. And you see specifically, if the glycemia is not target during the hospital stay, you see the mortality rate is very, very high, both in a USA-based study as well as a China-based study. We see the mortality rate has been very high. So the key is to maintain a better glycemic control, have a healthy lifestyle, and also we need to understand the glycemic status of the individual. As we were saying, many times we often ignore, and anyone with a family first degree relative with diabetes, they should be checking their HbA1c periodically. At least they should be screening for HbA1c at least once a year, once they hit 30. And especially during this COVID-19 pandemic, it has become even more relevant. So how to maintain glycemic control? You need to do glucovigilance, that is regular monitoring of your blood sugar with a finger prick method or a CGM study. And also you need to do relax. You need to get adequate sleep, about 7 hours a day, and then also monitor urine ketone levels, etc., for high-risk individuals. So this was RSSDI initiative, and I was part of this Defeat Diabetes campaign, where we urged the whole nation to measure their blood sugars on a particular day. So we reached out to 1 million people, and the keywords or the motto was a test, track, and treat. So we urged anyone during this COVID-19 infection to understand what is their glycemic status by testing themselves, and also if they're found to be pre-diabetic individuals, to track their blood glucose. And if they are diabetic individuals with dysglycemia, where the glucose was not to control, they should be seeing their doctors, getting themselves treating adequately. So this was the team headed by Dr. Bansi Sabu, and I was part of it. And what we are trying to convince is to declare blood sugar as the 5th vital sign. We know that during this COVID-19 infection, we had been monitoring the oxygen saturation very often, besides blood pressure, temperature, pulse monitoring, etc. Similarly, we are urging that blood sugar should also be considered as a vital sign, and everybody should be checking their blood sugar as often as they can. So also this was a social media based campaign where we are trying to reach out and educate people regarding the importance of blood sugar testing during this COVID-19 pandemic and beyond. And we're happy to know that just by Twitter itself, we reached out to about 130 million. So healthy lifestyle is very, very important. We urge that brisk walking at least 20 to 30 minutes a day is vital. Eat healthy, and also you need to manage your stress and anxiety. There was a prolonged, protracted period of lockdown where everybody was stressed. They were anxious about what was going to happen. And in this scenario, I think stress management is very, very important. We urge that everybody gets vaccinated because that's not only going to save themselves, but also the individuals who surround them, and also produce probably some amount of herd immunity as well. So immunity, we know that during this COVID-19 pandemic, everybody was taking over-the-counter vitamins like zinc, vitamin D, etc. They may have some amount of role, but what is more important for the type 2 diabetic individuals is to understand their diet, and the keywords that we use for diet in diabetic individuals is moderation of the carbohydrates and calories, and also maintain plate size, have lots of vegetables, have lots of colors, have more of protein, grains and dairy products. And we were talking about where we have adequate. So if you divide it in 4 corners, you have a lot more of vegetables, fruits, etc., and healthy protein, and also whole grains, and have less of carbohydrates. And you divide it into the zones, you have more of the green zone items, have lesser of the yellow zone items, and least of the red zone items that are shown in here. And this is mostly based on the Indian as well as the continental diet. About the exercise, we said that brisk walking at least 30 minutes a day for at least 5 days a week is very, very important, or any form of cardio exercises. And also do's during the lockdown, as we had known, use sanitizers well, wash your hands as a regular practice, maintain good personal hygiene. You know how to sneeze. You have been seeing this on the TV. Fold your hands and also dispose the tissues where you sneeze in. Maintain adequate social distancing at home. Avoid crowded places inside. And also, while you're going outdoors, make sure that you're wearing your mask properly, and stay hydrated. Monitor your temperature if required, and if you are on insulin, also monitor your ketone bodies once in a while. Monitor your blood glucose, as we have been talking about. Anyone who is taking alcohol, they should moderate drinking. If they're a smoker, they should stop smoking completely. Do not spit in public, and don't go out in public if you know that one of your family member is suffering from COVID-19, and quarantine yourself. So avoid touching your hands. Try and practice safe practices like avoid social gatherings, crowded places, especially indoors, and don't hide any of your medical travel history from your treating physicians, because that would help us understand. So we are continuously updating ourselves. We're evolving the newer strains of the COVID-19 virus that are being generated every single day. And we know that the vaccines are also going to be upgraded based on the newer strains. And this is today's data, according to NDTV, where the number of coronavirus cases in India is what you have in front. This is the number which is recovered, and the number of deaths till today has been this one. And this is the official number that we have. So thank you, be safe. And we know that you as a clinician has got a big role to play when it comes to managing the dual pandemic of uncontrolled diabetes as well as COVID-19 infection. And I urge you to maintain your own safety while you take care of your patients. So thank you, and hopefully this was of some help to you, and I look forward to any questions that you have for me at the end of the session. Thank you again.
Thank you so much, Dr. Suprati, for your presentation. It was indeed a very insightful session. Moving on to our last presentation for today, welcoming our international speaker for today, Dr. Ina Shaltut, who's a professor of internal medicine and diabetes at Faculty of Medicine, Cairo University, Egypt. Professor Shaltut's research includes the treatment of type 2 diabetes and the management of fasting during Ramadan for people with diabetes. She is currently the president of the Arabic Association of Diabetes and Metabolism and a member of EASD. She has also served as a peer reviewer for many medical journals, including Diabetes Research and Clinical Practice and the International Journal of Clinical Practice. Welcome, ma'am. Please go ahead with your talk.
Thank you very much for inviting me to be part of this important scientific event, and I'm going to talk about recent advances in therapeutics in diabetes. And let's start with the newest International Diabetes Federation figures for 2021 and the new Atlas of the International Diabetes Federation said that we have 537 million adults living with diabetes, and these 537 million living with diabetes gave a rise of 16% since the previous IDF estimates in 2019. Those are the 7 IGF regions of the world, and we can find in the Middle East and North Africa 73 million adults living with diabetes, and in Southeast Asia 90 million, and in the Western Pacific there is 206 million persons living with diabetes. The global prevalence of diabetes has reached 10.5% of adults, and almost half of these adults living with diabetes, 44.7% of them, they are undiagnosed. And the International Diabetes Federation projections show that by 2045, there is going to be 783 million adults living with diabetes, or 1 in 8 adults will be living with diabetes. The problem is that 4 in 5 people living with diabetes, they live in low and middle income countries. And these are the key global findings in 2021. 4 in 5 adults are living in low and middle income countries, and they don't have enough medications or enough medical care. And for mortality in 2021, there is 6.7 million deaths due to diabetes. And these deaths are excluding the mortality risk associated with COVID-19. They are due to deaths due to diabetes or its complications. They are 12.2% of the global deaths from all causes. We are also having 541 million adults, 10.6% of adults worldwide having impaired glucose tolerance, and they have high risk of developing type 2 diabetes in the future. 90% of people with diabetes are having type 2 diabetes, and this type 2 diabetes is driven by an interplay of socioeconomic, demographic, environmental, and genetic factors. And the key contributors include urbanization, aging population, decreasing level of physical activity, and increasing prevalence of overweight and obesity. Another key finding from the 10th edition of the International Diabetes Federation Atlas say that diabetes was responsible for an estimated $966 billion in global health expenditure in 2021. Then the global prevalence is increasing, and we have to find newer medications and tight control of glycemia and tight control of risk factors. These are diabetic medications starting since the discovery of insulin in 1922, followed by sulfonylurea, metformin, alpha-glucosidase inhibitors in 1995, followed by the TZDs, then the GPP4 inhibitors, exenatide, liraglutide, then dapagliflozin, empagliflozin, SGLT2 inhibitors group, followed by the glargine U300 and new insulins, degludec, and then semaglutide, ertugliflozin, and the combinations, the fixed ratio combination between basal insulin and GLP-1 receptor agonist, and we are having newer medications for diabetes. We are going to talk about some of them. And let me start with SGLT2 inhibitors, canagliflozin, dapagliflozin, and empagliflozin, because they have a landmark in anti-diabetic medications showing beneficial effect on cardiovascular disease and renal disease. They are inhibiting the reabsorption of glucose in the proximal renal tubules, resulting in loss of glucose in the urine and reduction of serum level of glucose. The excess loss of glucose causes a loss of calorie, reduction in serum glucose, and mild osmotic diuresis. This is a mode of action of SGLT2 inhibitors, sodium glucose cotransporter 2 inhibitors, and in the renal glomeruli, the filtered daily glucose is more than 180 grams per day, and this is reabsorbed later on in the proximal tubules by the SGLT2 and the SGLT1, sodium glucose co-transporter 2 and 1, mainly by SGLT2, which reabsorbs 90% of the filtered glucose, and the SGLT1 filters 10% and reabsorbs 10% of the urinary glucose. When we are using an SGLT2 inhibitors, it will lead to reduced glucose reabsorption in the proximal tubule, leading to urinary glucose excretion and osmotic diuresis. The fluorescein was isolated from the apple tree bark in 1835, and the fluorescein was found to promote glucosuria by a scientist, von Mering. He observed that dogs given doses of fluorescein above 1 gram, they developed glucosuria. Then the anti-diabetic effect of fluorescein was discovered in 1987, 100 years later, and the limitation of use of fluorescein as an anti-diabetic treatment was due to poor bioavailability and relative non-selective action, leading to diarrhea and the rapid clearance by the gut, kidney, and the liver after hydrolysis. And then the SGLT2 inhibitors were discovered in 1990. These are the known family members available in the pharmaceutical markets: the dapagliflozin, the canagliflozin, and the empagliflozin. They are taken once daily and they are rapidly absorbed with high bioavailability. These medications are beneficial in hemoglobin A1C reduction, besides some beneficial effect in the form of weight loss, cardiovascular protection, and renal protection. And after the withdrawal of rosiglitazone from the pharmaceutical market due to claimed cardiovascular side effects, the IDF requested all the new anti-diabetic medications to do cardiovascular safety trial. And cardiovascular safety trials are being conducted for each compound within the newer classes, and these are the known cardiovascular safety trial among GPP4 inhibitors, SGLT2 inhibitors, and GLP-1 agonists, and all of these newer medications had their own cardiovascular safety trial. But cardiovascular safety trial was not only to prove that these medications are safe on the heart, but some of them proved the beneficial effect on the heart. And let me now come to this question: does SGLT2 offer a unique cardiac protection or not? And this was first shown in one of the most important cardiovascular safety trials, the EMPIRIC outcome. It was a breakthrough trial in type 2 diabetes. It was done in 590 sites in 42 countries, and there was primary outcome of 3-point MACEs, and secondary outcome includes the 3-point MACEs, time to first occurrence of cardiovascular death, non-fatal myocardial infarction, non-fatal stroke, besides hospitalization for unstable angina. The other outcomes include the all-cause mortality and hospitalization for heart failure. These were the 3 arms, or a placebo arm, empagliflozin 10 milligram and empagliflozin 25 milligram, and the EMPIRIC outcome shows 14% reduction in 3-point MACEs, 38% reduction in cardiovascular deaths, which was a breakthrough actually in cardiovascular protection and prevention of complications, and 35% reduction in heart failure hospitalization, and 32% reduction in all-cause mortality. These are the proposed mechanism of benefits of SGLT2 inhibitors, either due to glycosuria or natriuresis, and glycosuria will lead to negative caloric balance, reduction in body fat mass, decreased epicardial fat, increased cardiac contractility, reduced inflammation and fibrosis, reduction in hemoglobin A1C, reduction in inflammation, in glucose toxicity, uricasuria, and a reduction in the progression of atherosclerosis, all these mechanisms will lead to cardiac and renal protection. Natural disease will lead to reduction in blood pressure, decreased arterial stiffness, increased tubular feedback, afferent arteriole constriction, decreased plasma volume, decreased myocardial stretch, decreased incidence of ventricular arrhythmia, and all of these factors will lead again to cardiac and renal protection. Is there a role for SGLT2 inhibitors in renal protection or not? This was shown in different molecules of SGLT2 inhibitors. For example, empagliflozin shows reduction of 39% of new onset or worsening nephropathy, reduction of 38% of new onset macroalbuminuria, and 44% reduction in doubling of serum creatinine. And for hard renal outcomes, new initiation of renal replacement therapy or death due to renal disease, there was reduction of 48%. These potential effects by which SGLT2 inhibitors improve the renal outcome, there was protection against diabetic nephropathy. The clinical effects was shown by stabilization of estimated GFR, reduction in blood pressure, reduction in tubular and glomerular injury, reduction of albuminuria, reduction in renal ischemic injury. And the most important factor in renal protection was reduction in glomerular pressure, showed by increased afferent vasoconstriction and decreased glomerular hyperfiltration. And this is in vivo imaging analysis demonstrating afferent arteriole constriction following SGLT2 inhibitors therapy, and the image of afferent arteriole before and after empagliflozin, and before the medication and after medication. To the right side of the slide, there was a constriction of the afferent arteriole. Those are the cardiovascular outcomes in different SGLT2 inhibitors. And for the 3-point MACEs, the EMPIRIC trial showed a reduction of 14%. The Canvas program showed 14%, while in the DECLARE A.CME, it was non-significant. The cardiovascular deaths were reduced in EMPIRIC, 38% reduction, and it was not significant in Canvas or DECLARE. The hospitalization for heart failure is a group effect, and it was reduced in EMPIRIC trial 35%, and in Canvas 33%, and in DECLARE A.CME 27%. And the kidney outcomes were reduced 39% in EMPIRIC trial, 40% in Canvas program, and 24% in DECLARE A.CME. Let me now start to talk about an overview of the GLP-1 receptor agonist, and these are the benefits of GLP-1 agonist. There is low risk of hypoglycemia, but slightly higher risk when they are used with sulfonylurea or insulin. They lead to weight loss. There is potential for once daily or once weekly dosing, and studies shown addition to basal insulin can be effective as starting a pre-meal insulin. The same effect actually between the fixed ratio combination of basal insulin together with GLP-1 receptor agonist, as if we are giving basal bolus regime. These are some side effects and contraindications. The adverse effects are nausea, vomiting. They are most common adverse effects. Cases of acute pancreatitis, while the contraindications and precautions are if the GFR is less than 30, we don't use exenatide. There may be an increased evidence of gastroparesis. It is contraindicated in the history of pancreatitis. a history of medullary thyroid carcinoma, and history of multiple endocrine neoplasia, men 2. These are the different GLP-1 agonists, the exenatide or Byetta. It is used twice daily, timing with meals. Later on, we have now the once weekly exenatide, followed by the subcutaneous mini pump of exenatide for 1 year, but it's not yet approved. The liraglutide or Victoza, it is used once daily. The dulaglutide, Trulicity, once weekly dosing. The lixisenatide by Sanofi, once daily, and it is approved since 2016. Albiglutide, produced by GSK, but it was removed from the market due to limited prescriptions. Semaglutide by Novo Nordisk, it is either weekly injection or daily oral. And these are the main effects of GLP-1 receptor agonist. And the main action on the pancreas is reduced glucagon secretion and increased insulin secretion and biosynthesis, and reduced apoptosis of beta cells. On the intestine, there is the reduced postprandial lipids. On the platelet, there is reduction in platelet coagulation. On the heart, increased cardiac protection. On the fat and liver, there is reduced inflammation. On the kidney, increased natriuresis and increased diuresis. On the blood pressure, reduced blood pressure. On the brain, there is reduction in weight and reduction of appetite and increasing satiety. Let me start talking about exenatide. Exenatide, now we have the once weekly exenatide by Durian, and it is a single-use auto-injector device. The semaglutide, Ozempic, it is approved 2017 by Novo, and we start with a dose 0.25 milligram once a week, to be increased after 4 weeks to 0.5 milligram, and to be increased after 1 month or 4 weeks, if needed, maximum dose of 1 milligram. Semaglutide has multifactorial effects across different disease groups. On NASH, they reduce inflammation, reduce body weight, reduce lipids, glucose, and improve liver enzymes. On obesity, they reduce energy intake, reduce appetite, and reduce weight. On kidney, reduce inflammation and systolic blood pressure. On cardiovascular disease, reduce inflammation, lipids, and systolic blood pressure. On diabetes, they improve insulin sensitivity, they improve insulin beta cell function, reduce glucagon secretion, and delay gastric emptying. What about GLP-1 receptor agonist and NASH, which is a common comorbidity with type 2 diabetic patients? And this is a study done on liraglutide in NASH patients. Those NASH patients were either having type 2 diabetes or not, and they were given liraglutide 1.8 milligram, and the results showed reduced weight in those receiving NASH versus the placebo group, improvement in ALT in 26% of cases of liraglutide, and also there was a NASH resolution in 39% of cases of liraglutide compared to 9% in cases of placebo. Now I come to the fixed ratio combination of GLP-1 agonist with basal insulin, and this is a Soliqua produced by Sanofi. And the Soliqua, we have 2 types of pen, the peach pen and the olive pen, with different fixed ratio combination between the basal insulin, insulin glargine, and the lixisenatide. It's a combination, and it is approved for patients uncontrolled on basal insulin, and they are once daily dosing, and it have the benefit of reducing of both fasting blood glucose and postprandial blood glucose. Let me talk about another fixed ratio combination produced by Novo, which is insulin degludec and liraglutide, Zoltofil, and it's used also once daily, and it is titrated by 2 units every 3 to 4 days until the fasting blood glucose is at goal. Now to the last question, my presentation, what are the oral and injectable therapies in the pipelines? These are different medications present in clinical phases 1, 2, and 3, and they are either oral or subcutaneously injected, and they are gastro-inhibitory polypeptide receptor agonist, GIP, or GLP-1 receptor agonist combination, and glucagon-like 1 receptor agonist, and other groups, gastric inhibitory polypeptide receptor 1, interleukin receptor antagonist, interleukin 8A and 8B receptor antagonist, glucagon receptor antagonist, gene transferase, interleukin 10 replacement, glucokinase stimulant, sodium glucose transporter inhibitor, newer medications, glucagon receptor agonist, glucagon-like peptide stimulants, and they are also either oral or subcutaneous medications. Another group of medications in the pipelines, dipeptidase inhibitor, newer medications, gene transferase immunosuppressants, T lymphocyte replacements. They are also subcutaneous, oral, or intramuscular medications. Let me introduce you to sotagliflozin, and it is discovered using lexicon unique approach to gene science. It is an oral dual inhibitor of 2 proteins responsible for glucose regulation. They are known as sodium glucose transporter 1 and 2, SGLT1-2 combination. And another newer medication, amiglymine, and it is a novel drug completing phase 3 in Japan, and it is under regulatory review and anticipated to be launched by the end of 21, and it is in phase 3 in US and Europe. It is the only oral medication compound with dual mechanism of action directly to increase insulin secretion in response to glucose and to reduce insulin resistance. Another newer medications, dual GIP and GLP-1 receptor agonist. It is a biologic entity acting as a co-agonist for both GIP and GLP-1 receptor agonist, and it is studied for the treatment of diabetes by Eli Lilly and company. And let me end my presentation by this novel once weekly basal insulin. It is safe and effective in type 2 diabetes, and it will be produced by Eli Lilly. It is a novel once weekly formulation of basal insulin. It was shown to be safe and effective when compared to degludec in a clinical trial for 32 weeks. And it had lower rates of documented and nocturnal hypoglycemia. This once weekly insulin had a flat peak, and there is reduced within day glucose variability, which was very beneficial and is very promising, and it is potentially lowering the risk for hypoglycemia. Thank you very much.
Thanks a lot, Dr. Shaltut, for this beautiful presentation. Indeed, a very well-researched talk. So this brings us to the question and answer segment. Our first set of questions are for Dr. V. Mohan. Sir, your first question is the negative calorie balance targeted towards obese T2DM only, or does BMI not play a role?
A, B, C, D, E mantra, I talked about B. B is body weight and BMI. Now, if you have somebody who has a lot of weight to lose, let's say his ideal body weight is 60, he is now 90, he's got 30 kilos to lose. That would be the person where you can expect a lot of, just imagine the fat in the pancreas and fat in the liver. Okay, who will have more of fat? Not a thin person who's coming, where fat he'll have, he's so thin, he's malnourished. So these people who have the mechanism itself is by fat melting and going away. So it will be invariably people who have this. There's only one exception. Sometimes we know that there are subtypes of type 2 diabetes, and there is one subtype called as SID, severe insulin deficient type. These are 4 subtypes which we described in India for the first time. The severe insulin deficient variety, insulin resistant obese diabetic or IROD, the combined insulin deficient and resistant variety, or the CIRDD, third variety, and the mild age-related variety. Mild age-related variety, forget about it. This is what constantly remission occurs. Their HbA1c itself is only 7. Then they bring it to 6.5, 0.5%. Oh, remission. That's the easiest to occur. Don't even talk about it. So easy. I'm talking about the other 3 types. In the IROD variety, where there is insulin resistance, is where you ask about body weight. If their body weight, they can lose it, and then they can get rid of their diabetes in some cases. But the first type, the severe insulin deficient type, is very difficult to reverse because they have a severe insulin deficiency. But even in such cases, what we have found is early and aggressive insulin treatment, giving insulin for about a month or so. I published this, spoken about it in so many conferences, and is quite well accepted now, that if you give them a course of insulin, what happens is the beta cell function can improve, okay? And their HbA1c can come down dramatically. I've seen patients with HbA1c of 14, 15 come down to 5, 10% lowering of HbA1c. And then the beta cell picks up, they gain a little weight actually, because they may be underweight because of uncontrolled diabetes. And then some of them can go into remission. No insulin, no tablets, nothing. So that is one exception if you treat it very aggressively. But normally the remission is for very obese people.
Thank you, sir. Your next question is, how does diabetes remission work in cases of patients with normal weight, type 2 diabetes mellitus?
You have to, in normal weight and obese people, normal weight people or normal weight people, you don't have much of fat to lose. So that mechanism cannot work. The only way you can do it is by improving the beta cell function. So either you give them a short course of insulin to improve the beta cell function, or sometimes drugs like low-dose sulfonylurea or the DPP-4 group of drugs, which help to improve the beta cell function. By doing this for a short time and improving the beta cell function, you may be able to reverse the diabetes. But we don't have enough evidence. Like a direct trial is only in obese and overweight people. So in lean people developing remission, we don't have, except for this early insulin therapy, we don't have the evidence till now.
One last question for you, sir. Do you think dietary control and weight loss for diabetes remission can lead to negative adherence to medical treatment?
Because, what happens is, this is like a kind of a war-like situation, the people who have got into this game, I would call it a business. It's more than a game, it's a business. They're getting, huge amounts of money and saying, we will now reverse everybody's diabetes, and they form a company, and now they're calling everyone and saying, you join our program, you stop all your medicines, and 4 weeks, we'll be able to stop your medicines. And so the whole idea, the bait with which they're calling people is stopping medicine. Okay. So people are only bothered about that. And so naturally they put them on a very low calorie diet, very low carbohydrate diet. Suddenly the sugar will come down, all the medicines are stopped, and patients are so happy. Oh my God, a savior has come down from heaven, and he has now taken me off insulin. My doctor told me to take medicine. Look at the savior who has come. He has now taken me off all medicines, and I know I've been saved now. Okay. What they don't understand is that, okay, at that particular time, the sugar comes down, the weight comes down, everything comes down. And I showed you the classical case where they go off medicines. What happens later? Once you have gone off medicines, it's a human tendency, People will think, I'm cured. First, they'll start having one gulab jamun, they'll have some day. Then something else they'll have. Their exercise, they'll stop because they already lost some weight and they're feeling on top of the world. And then what happens is one by one, they forget that they have diabetes. This is the thing. They forget that they get diabetes. Of course, they're not going to take their medicine. And because they're so convinced in their mind that my diabetes is gone, they won't think of going to a center. They won't think of testing. They won't think of re-reversal, that it can come back. Even people with cancer make the same mistake. Very often, the oncologist will say, see me every 6 months. Please come back. They won't go. 5 years is gone now. I'm totally cured. And then when they go, it has spread all over, and then it's just too late. So same thing happens here. If you delay too much, and a negative adherence to medical treatment can come, because they're almost told that if you take medicine, it's bad for you. Medicine will damage your kidney. Medicine will produce this. Medicine will produce cancer. Medicine will produce this. Medicine doesn't produce anything. It's like a sharp knife. If a surgeon uses a sharp knife, he'll make a nice, beautiful incision without even a scar. He will do that. You give a sharp knife to a child, it'll cut itself all over. So it's like that. Medicines must be given by qualified endocrinologists, diabetologists who know how to treat. So once you take that, taking a medicine is not a bad thing at all. Many of my patients, and I published that, spoken about it in so many places. In fact, I got the Harold Ritkin Award for that. So what we showed was people who have taken medicines and kept their A1Cs under control for 50 years, 60 years, without any complications at all. Several cross 100 years of age. They finish 100. They're still okay. They're doing fine. They're walking about. They're doing everything. Their brain is good. Their muscles are good. Their body is good. The bones are good. Everything is good. And they've crossed 100. They're 100, 101 years old, doing extremely well. The faculties are all there. But they're still taking a small dose of tablet. So what? Well, the whole idea is not to stop medicine. The idea is to make you live up to 100 without any complication. And we've shown it again and again. 2-3 publications, we have shown that it's possible. For the first time in India, we are able to show that. So to me, the whole aim of treatment is to give a long and healthy life to somebody by controlling the diabetes well, by controlling the sugar, blood pressure, cholesterol. If you control these three well, they'll be able to have a long and healthy life. The whole idea of treatment is not to stop treatment. Okay, first of all, you got a defect, you got a beta cell defect. That's why you develop diabetes in the first place. How can my first aim be to stop all the medicines? So that is what patients think, that that's the greatest achievement. If you can achieve it, it's good. But as I told you, only very few will achieve it, and even less can continue it lifelong. So my thing to all doctors and to all patients would be, you change your focus. Keep your focus. How do we ensure that this person has a long and healthy life despite diabetes? That's all. If you keep it like that, incidentally, a few may have remission also. I think that's the best way to approach this problem.
Thank you so much, sir. Our next set of questions are for Dr. Supratik. So your first question is, lockdown has altered sleep-wake circadian rhythm significantly. So could you stress on how important is sleep for children with type 1 diabetes?
Sleep is very, very important for the well-being of the individual. And we need about 7 to 8 hours of sleep. The children require slightly longer based on the age of the child. And so in general well-being, to de-stress yourself, to generate the energy that you require, and also to combat disease, adequate amount of sleep is very, very vital, along with the diet, exercise, and lifestyle modifications that we have been talking about during the course of our talk today. I think we're sleeping very late nowadays. The entire timings have changed. It has been a very difficult time for all the children because they had been attending their classes online, and there's a much higher screen time which is there. And because of that, when they're using their cell phones or their iPads or computers at night, there's a significantly delayed sleep time that is there. So I think that is one of the habit, like we need to change the habit of these individuals by reducing the screen time and urging them to take, the sleep hygiene, where we urge that they should be switching off their devices. And while they go to bed, they should have a very quiet environment where, you switch off the light, you have minimal sound possible, and you do not use your device while you're lying down. So these are some of the things that you can use as a tip for increasing the sleep hygiene.
Thank you, sir. Your next question is, during the initial stages of lockdown, patients had difficult time obtaining medicines as well as monitoring devices. How should one be prepared for such scenario in the future?
This has been a practical limitation for us, and it was a challenge where patients could not reach the facilities to get their tests done, whether it's the blood sugar or otherwise. And we did urge them to get their monitors, the glucometers, the pulse oximeters, etc., handy at home, and even the blood pressure monitors at home, so that they could check the vitals. But indeed, I understand that initial phase of the lockdown, even the availability of medication has been a problem. So we urge that you should be judging the situation. If you feel that there's a chance that there is an ongoing lockdown that is going to be in place, then you order your medications in advance so that you have enough stock. Keep a glucometer at home, keep a blood pressure monitoring device, as well as a pulse oximeter. So these are the minimal things or the most vital things that you can have if you can't reach the facilities where these are being done. Some of the studies have shown that type 1 diabetes significantly improved during COVID-19 lockdown despite reduced activity. It could be because of parents who were forced to stay at home and make time to deal with the disease.
One last question for you, sir. Some of the studies have also shown that type 1 diabetes significantly improved during COVID-19 lockdown, despite reduced activity. So could it be a result of parents who were forced to stay home and had more time to deal with the disease?
So yeah, glucovigilance is very important. So COVID-19 did give us the opportunity to eat healthy. So many of the children who were eating snacks, eating, say, outside food, they're binging on calories. When they were at home, they're getting home cooked meal, which was healthy. And so that probably would have reflected. At the same time, they were under supervision and they were monitoring their blood glucose more often than they could with their difficult lifestyle earlier. So all of these could have actually contributed to a better glucose number when it came to the type 1 individuals. But they still remain theoretical. We do have other data where we have seen that the glucose levels deteriorated during the COVID-19 pandemic, and possibly this was because of less physical activities during this lockdown period.
Also, before we close the session, I would like to know if any of you have a closing remark for our audience. So Dr. V. Mohan, if you want to go first.
So on the occasion of World Diabetes Day, tell people that diabetes is an asymptomatic disease, so don't wait for symptoms. Even without symptoms, you can get diabetes. If one person has diabetes in the family, look for other people. And most importantly, if you remember the ABCD mantra, they keep the A1C under control, blood pressure under control, and the cholesterol under control, and D, no smoking and have some discipline. D stands for discipline. Then you can have a long and healthy life despite diabetes. And we have proved this again and again through our research publication. I have so many YouTube videos also where I talk about this. Thank you.
Thank you, sir. Any words of wisdom from Dr. Supratik Bhattacharya?
World Diabetes Day on 14th of November. This is an initiative that diabetologists and endocrinologists across the world are involved in. And the theme for the next 3 years is, for the diabetic individuals, is accessing the diabetes care, which has been lacking for a considerable period of time. So many of the diabetic individuals probably cannot reach the facilities where the testings are being done. And especially with the COVID-19 pandemic in place, we knew about the challenges that they faced in actually accessing the healthcare facilities that were required. So I think for the next 3 years, we will be concentrating on that. More importantly, 14th of August, which was 3 months in advance, was identified as the Pre-Diabetes Day. And this was again a welcome initiative. I think we need to understand that there is a significant proportion of the population which is submerged. So this is the bottom of the iceberg, which go unnoticed, and they're completely unaware that they would be having pre-diabetes, and they should be actively searched for. We should be doing screening for these individuals. Anyone with a first degree relative or anybody having higher risk for developing diabetes, like obesity or otherwise, or sedentary lifestyle, etc. We need to actively screen for them to see whether they're pre-diabetic and advise healthy lifestyle, diet modifications, exercises for them so that we can prevent them from ending up in diabetes. So my message to all my peers and the audience today is that we are in it together, and we can defeat diabetes, as we had been saying, if we work together, if we help our patients understand the importance of glucose monitoring and control of blood glucose in the long term to prevent complications. So thank you again.
So this brings us to the end of the CME session. On behalf of DocPlexus, I would like to thank Dr. V. Mohan, Dr. Supratik, and Dr. Shaltut for their time and valuable insights on this CME session. To our audience, hope you liked today's session as well. And thank you for your support and participation in this 3-day DocPlexus Global Diabetes Summit event. Please share your feedback, if any, and questions if you have. Please have a great evening ahead and take care.